So, a very good morning to all of you. I am Dr. Rahil Chaudhary, and it's a beautiful day at APAO International Congress. And I have the privilege of sitting with Dr. Ashraf. He's the managing director and founder of Ashraf Eye Clinic Hospital in Cairo, Egypt. And I was interacting with Sir. Sir has authored multiple books. He has been an active participant in ASCRS, ESCRS conferences where he's taking multiple instruction courses. And Sir is also the founder of AOTOA, which is the Armia's Ophthalmology Training and Observership Academy, and also the founder of GERSO, which is the Global Education and Research Society for Ophthalmology, and also ISRS Editorial Board in Cairo, Egypt, with shareholder of Watani Eye Hospital. So, sir, lovely to have you here for this podcast. Is it the first time you're visiting?
It's very pleasure to have this podcast with you, Rahil. I'm following you also for many times. You are doing a great job in ophthalmology. This is not the first time in India, but the first time in Delhi. I came for the first time in India in 2019.
Wonderful.
I love India. I love Indian people. I love the spirits. You are really a cozy country that makes people easy to live. So I'm happy to be here.
Well, thank you for those kind words, sir. The first question, what I want to ask you is that we see that with the increased usage of screens these days, lot of youngsters are coming in with dry eye problems. So, in a clinical setting, how do you make a diagnosis for the patient?
Very nice highlight, Rahil, because in the last 4 years since the Corona period and the COVID, we noticed a lot of people, young in the age of 16, 18,
Yes.
coming to our clinics complaining of um, not a quality good vision, in spite they don't have a refractive errors, but they are not happy people. So when we re-examined deeply, we found that they started ocular surface problems in this very young age without any problem in the systemic diseases.
Absolutely.
So definitely, as you said, it's a part of the problem of the long-term screen looking either the mobile, the iPads, the computers.
Yes.
You are totally right.
Yes. And
How many in India you see people like
so
this?
suppose 100 dry eye patients come to me, almost 50% of them are youngsters
And how about the age?
who are below the age of 30
Yes,
years. They're
exactly,
presenting with these problems.
exactly,
And we all understand that when you are on the screens, the blink rate reduces drastically. So
exactly.
somebody was supposed to blink, a normal person is supposed to blink about 16 to 18 times in a minute, but when you're focused on the screen, it goes down to 6 to 8 times a minute. And that is where we feel the real problem started.
You know, one of the weird symptoms from the young adults, they tell me that there is a foreign body sensation.
Yes.
This is a weird complaint for a young adults, 16, 18. This is an early sign of ocular surface disease, which is we didn't heard before in the last 10 years.
Yeah.
So it's a coming, ocular surface disease becoming booming, and it's becoming early in ages. So we should um, think about it and highlight it in our clinics.
Yes. So, sir, when somebody comes in with this all these foreign body sensations and sometimes hyperemia with red eyes and also, then what tests are you doing to come to a diagnosis?
Let's make it simple for because some clinics are simple clinics. So the easiest for me is start with examining the ocular surface, the edge of the lid, the meibobbing glands, the wrinkling of the conjunctiva, putting fluorescein to see how a staining of the cornea, what the tear breakup time. This is the simplest for anyone.
Yes.
If you have a more sophisticated clinics, some of the, we as we have it. So epithelial mapping for me is one of the best detection of the ocular surfaces. I have the privilege to have an eye trace also. So the eye trace also give me a lot of issues about the high order abrasion.
Yes.
It's rare to find in a young adults high order abrasion without refractive error
Yes, yes.
and without cornea problems, unless the ocular surface disease has a problem. So when I see that it's had a high order abrasion, I go for more sophisticated. I usually go for the tear film evaluation, the meibomian gland dysfunction, a lot of things. What about you?
Yeah, so how I start is that I am still doing the Schirmer's test because sometimes I feel that I have to refer the patient to a rheumatologist and they need this test for the
Exactly.
diagnosis.
Yes.
Plus, when the patient is coming in, the first thing that I'm doing is a detailed questionnaire. So I'm spending about 10 minutes with the patient, trying to understand his lifestyle, his habits. That brings me a lot of insights into the diagnosis. Then the next step that I do is the fluorescein staining,
Exactly.
and I'm
True.
looking for any dry spots, and I'm
So,
looking for
so you start with the simple, then the sophisticated.
yes, yes.
Perfect.
So the fluorescein stain gives me that tear film breakup time. I'm able to have a look at that. And after this, I'm sending the patient for the higher evaluations, like you do so. So then we have the tear check machine with us. And the two important things I'm looking in that is the architecture of the meibomian glands and the thickness of the lipid layer. So most of the times, if you just tell the patient that you have dry eyes, the patients find it hard to believe that at a young age I'm having this problem. So most of the times what I do is that I keep the meibomian gland image in front of the patient and I show him how a normal gland looks like. And I want to highlight that these are all straight. The gland should be nice and straight. But if the glands are becoming waving, if the morphology is changing, that they are constricting, the lumen is reducing, so the patient is very easily able to understand the difference between a healthy meibomian gland and a diseased meibomian gland. So that really motivates him to take treatments.
I will take from you words about the questionnaire. In my clinic, I have the questionnaire, but I have different type of questionnaire according to a lot of things, according to the social level of the patient, the mental status, and how he's going to answer my questions. So usually the questionnaire getting higher and higher according to the level of social education and mentality of the patients.
Definitely.
Because sometimes sophisticated questions, it's not be easy for anyone to understand. So this is how I change a lot in the questionnaire in my clinic. Very important issues that you mentioned the meibomian glands, because this is I can remember since when I started ophthalmology, the senior of me took me to the slit-lamp in I think 1996 or 7, and he told me, Ashraf, look to the sign. This is the early sign of meibomian gland inflammation, which is meibobinitis. I cannot forget this day because I saw on the slit lamp a sign of ocular surface disease.
Yeah.
So this is very important. Slit lamp is crucial in these cases to make the patient aware of the problem you are seeing. You know more the patient, but the patient should know what you see.
Yes.
So this is very crucial.
Yeah.
Agree, totally agree.
So just showing them the meibomian gland pictures convinces him that there is a problem and it needs to be addressed. So, sir, when somebody is coming with these problems, how do you proceed with the treatments? Because we understand that as of today, the medicines or the drops which are available are primarily treating the aqueous deficiency part of the dry eyes. But most of the times, we see that patients are coming in with a mixed form of dryness. So in my practice, I'm doing a combination of the topical treatments combined with the IPL therapy. Do you follow a different approach?
You are touching the points. I think we start in any management in any disease in our ophthalmology fields. You start with the simple till you reach the sophisticated management. It depends on the diagnosis and the level of the disease you reach. So in simple dry eye cases or ocular surface disease, you don't need too much sophisticated. So, in my opinion, I start with the lid hygiene.
Yes.
Simply, and especially in younger, hygiene, hot fomentation. If I found that there is a meibrovenitis, closing the opening of the meibrovenitis, I do squeezing for the lids. I do topical steroid to decrease the inflammation of the ocular surface disease. I add artificial tears according to the problem, the simple or the lipid supplements like this. I change the dietary life of the patients.
Yeah.
We go more for antioxidants, especially the omega. And this is how it goes for the simple for me. And I follow the patients according to the questionnaire, and I repeat it after 1 month to see if it's going on the positive side or still the patient is still complaining.
Yes, yes, yes.
So this is how I start the simple.
Definitely. So when somebody is presenting with mild dry eyes, initially what I recommend them is that you start using a basic lubricating drop, use it 4 5 times a day. Then lid hygiene, of course. So we advise them to clean lid margins every day, maybe with a lid wipe. Yes, eye wipes, tissues which are available. So we ask them to clean the upper eyelid and the lower eyelid before they sleep. And then we also advise them that before sleeping, they should heat their lids and do some massagings so
Exactly.
that the flow is restored to a level. And then if these therapies are not working, then we call them and then we add those steroids and cyclosporins. And if that doesn't work, then we start with the eye fill therapies.
Totally agree. Um, Also, we differentiate between ocular surface disease for young or ocular surface disease before ophthalmic surgery,
Yes, yes.
either refractive surgery, cataract surgery, or glaucoma surgery.
So that was
So,
exactly my next question.
yes, exactly.
So in my practice, sir, whenever I'm dealing with a patient who's coming in for refractive surgery or cataract surgery, I make it a point that I evaluate them for dry eyes before I do the surgery. Because let's take an example of cataract surgery, and suppose we are doing premium cataract surgeries. So many times we see that patient has poor ocular surface, you give them treatments, and the biometric values change, the astigmatic values change. So, do you also follow a similar approach?
Yes, I totally agree with what we are saying. We are all ophthalmologists looking for our patient to be happy.
Yes.
And if we are looking for our patient to be happy, you should make your clinic a premium clinic. In my opinion, premium clinic is proper preoperative evaluation, proper intraocular manipulation, and the most important, premium postoperative uh, follow up the patients. So if you make this premium clinic with your mentality about the ocular surface pathology in our patient nowadays, you are going to reach nearly happy or 20 happy patients.
Yes.
This is my opinion.
Yeah. And what about the refractive patients, sir?
Refractive patients, as you definitely know, that these patients coming to your clinic seeing perfectly, seeing 2020, and these people will never accept to have a post-operative problems. So these people, in my opinion, these patients are very critical patients, especially the refractive corneal patients. They need a special way to preoperative evaluate the patients. Anything you are going to miss it in the preoperative evaluation, you are going to face with a problem postoperative in these refractive patients.
Yes.
So in my opinion, the first thing to highlight or to look for is the ocular surface disease. Because this is a big correlation between ocular surface disease and the refractive error of the patients.
Yes. Yes.
So if a problem the patient has an ocular surface disease, so definitely the refractive evaluation for your patient will going to be not the proper refraction. So when you put the data of your preoperative refractive errors to the machine that is going to correct your refractive error in the cornea for your patients, so you are doing wrong data input. So definitely post-operative result will going to be not correct.
Definitely. So I think this is for the doctors which are hearing us, our audiences. I think the two most important things to evaluate if we are doing a refractive surgery would be pentacam and the dry eye evaluation, because that can really make the difference between the quality of vision, that 6.6 and 6.5 vision that we sometimes want to deliver to our patients. So that
Hi- Highly agree. I just add for the refractive surgery epithelial mapping.
yes, definitely.
Because epithelial mapping nowadays can give us a lot of things about the health of the epithelium, either the relation between the ocular surface disease or it's a problem in the cornea, early detection, and also in query cases when you do a corneal refractive surgery, cornea biomechanics. It's becoming now a mandatory in this field in cases you have a query results.
Yeah.
So this is important in corneal refractive surgery.
And suppose, sir, let's talk about post refractive surgery patients. So we feel that about 50 to 60% of the patients, they respond very well to the lubricating drops and the anti-inflammatory drops, but still some people need extra help when they become slightly refractive at times. So would you advocate maybe using IPL therapies for them?
Two important complications can happen, or not a complication, sorry, I can say um, um, not making the patient happy. Post refractive surprises because you didn't control the ocular surface disease
Yes,
and you're facing with the unexplained astigmatism. And the other issue is corneal pain.
yes.
A lot of our patients, 2020 vision, they are feeling pain in their eyes. And some of the clinics say you should go to the pain management, you should go to psychiatrist, you don't have anything. One of the main causes of pain post LASIK is cutting of the nerve fibers in the cornea that you did during any cornea refractive procedure,
Yes.
either surface ablation, either LASIK or femtolasic, or even a femtosmile. Because cutting the nerve fibers, regeneration of the nerve fibers is different from one patient to another. So why people, some of them feel pain? Because the regeneration of the nerve fibers is not equal in all patients. So in these patients, IPL is crucial if you found that the level or the meibomian glands um, percentage loss in these patients are becoming high
Yes.
post-operatively. So one of the major important management is the IPR.
Yes. Plus, not just the lipid layer thickness, the other benefits of ICL reducing the inflammation and everything also gives extra satisfaction and comfort to the patient. Also, sir, we understand that when we have patients of glaucoma and they have to put those medicines almost all their lives, and we understand that at some point they would also start developing dry eyes. So, do you pre-counsel these patients at times?
Very thanks for highlighting this because some people look for the glaucoma that they are miserable people
Yeah.
and the optic nerve is being lost and it's a process of losing vision. But still, these patients are living in life and they want to live their life in a good way.
Yeah.
So we can categorize the glaucoma patients in two categories: patients on medication, topical medications,
Yeah.
and patients who are going to do surgery. So patients who are going to do topical medication, especially if they have a preservative. So definitely the ocular surface disease are going to be uh, dysfunction.
Yes.
So measuring of the ocular surface disease, the tear film stability, the level of the meibomian glands, the how much the meibomian glands are lost is very important because these patients can be on eye drops for a long time. So you need them to enjoy life. Yes, they are has a compromised optic nerve,
Yeah.
but they need to live their life. They need to work. They need to drive everything. So maintaining the ocular surface disease in these patients is very important. The other issue is any surgery will going to be done in glaucoma. Any surgery causes inflammation. an inflammation of the cornea because you are touching the cornea,
Yeah.
or doing any procedure in the conjunctiva. So you are producing inflammation. Producing inflammation results in ocular surface disease dysfunction. So measuring the level of the ocular surface disease is very important in these patients, especially before and after glaucoma surgery.
Yes. So, when we are talking about the indications of IPL, what we've discussed so far is that we are using these therapies for primarily MGDs, ocular rosacea, sometimes telangiectasias, lid issues, lid hyperemias. And then we are also using these therapies for our cataract patients, our refractive patients, glaucoma patients. Any other indication you feel where this therapy could be of benefit?
The basement membrane corneal dystrophy,
Hmm.
one of the most important diseases that cause ocular surface disease. If you misdiagnosed it, so you can miss the ocular surface disease.
Yes, yes.
And treating the basement membrane dystrophy in these patients can lead to a good ocular surface disease. Also, in my opinion, now we are talking about premium cataract refractive surgery.
Yes, yes.
So if you are going to do this and you're going to have the patients 20 happy, if you are detecting ocular surface disease before this operation, you should go for IPL to leave the lid margin healthy. And post-operatively, you should follow these patients. And any starting ocular surface disease or lid problems, you go for another sessions for IPL because you want your patient to live his life as you planned, as a premium refractive life for these patients.
Yes. A lot of ophthalmologists are of this opinion that these IPL therapies are not beneficial for patients with Sjögren's. But I have done these therapies in my Sjögren's patients and I feel that they do benefit. What would be your opinion on this?
Very good questions. As we all know that Sjögren means we have a goblet cell deficiency, and some of them has a stem cell deficiency. So definitely the response to the IPL for Sjögren disease is not for the normal ocular surface disease. But they are benefited from the IPL in Sjögren, definitely the benefits. But also we should combine with either we do stem cell deficiency, transplantation, which helps a lot in these patients, but also systemic control of the disease with the IPL give the best result for the IPL.
It does work. It does.
Yes, it does work.
Usually the IPL protocols is 3 sittings. But sometimes we feel that additional sittings are required. So I've had patients who have required 6 sittings or 9 sittings to become comfortable.
In my opinion, it depends on the category of the ocular surface disease. If it's mild to moderate, or if it's moderate to severe, and we are going for a surgery, so definitely the surgery will going to complicate the stage. So following the patients, in my opinion, don't look for the number of the sessions. Go for the health of the ocular surface. So as much you need a session, go for a session.
Is there an upper limit? How many sittings can somebody get done?
In my experience, I didn't heard that there is a limit,
Hmm.
but in my opinion, if you need, like the intravitreal injections,
Yes, yes.
we are treating the exudative detachments. So once we control the AMD and it's right, we go for following every 3 months for the OCT. Once you feel any start, we go for injection. And this is the PRN for area. In my opinion, the ocular surface disease treatment is like this. If it's stable and you find that with all the investigations, everything is stable, don't do anything. But if you find that the patient is starting to complain, or by investigation you start to find a new, go for the IPL session.
Yes. Wonderful. So I think we've had a wonderful podcast today, sir. We've highlighted the main aspects of dry eye diseases. We understand that the questionnaire is one of the most important things. It gives you insights into the history of the patient, into the lifestyle of patient, risk factors that could be associated, any medication that could be creating problems. And then we also discussed that treatments, we have the topical treatments also with lubricating drops, steroids, and cyclosporins, anti-inflammatories. And then we have therapies like the IRPL and IPL therapies, which help the parasympathetic pathway to increase the meibomian gland, the lipid layers, and plus reduce the inflammation. And we also discussed that for specifically for premium cataract patients, for refractive patients, for glaucoma patients, for chalazion patients, these treatments are working very well. Anything else, sir, would you like to add for our audiences?
It was a pleasure to make this with you, Rahil. I was happy that we highlighted one of the most important problem in our practice, the ocular surface dysfunction, and we both together take it from the simple to the advanced, and with the treatment with the topical till the procedures in the lids. So this is very high educative for anyone. So happy to do it with you.
You think this ocular surface problem is highlighted, undervalued?
In my opinion, it's underestimated. Why? Because people before the COVID is different than people after the COVID.
Yes, yes.
Before the COVID, not more many people was looking for ocular surface.
Yes, yes.
In my opinion, that the COVID area or the COVID time highlighted many issues in the world. One of them, ocular surface disease.
Exactly. Because 4 years back in my practice, I was hardly checking anybody for the ocular surface problems. And now it has become a mandate in my everyday.
I totally agree.
Right. So Ashish sir, it was a pleasure having you here. Thank you so much for taking out time. And I hope you like India, you like Delhi. Most welcome whenever you visit next. We will have a good time together, maybe another podcast together.
Thank you so much. Thank you so much.